The next session of the day is a plenary session and will be given by Professor Gwen Jull and Professor Anne Moore. Professor Gwen Jull is an emeritus professor in the Division of Physiotherapy at the University of Queensland, Australia. Her research, teaching, and clinical interests are cervical disorders, particularly cervicogenic headache and whiplash-associated disorders, manual therapy, and quantifying the dysfunction in the cervical, neuromuscular, and sensory motor systems as a basis of therapeutic exercise in the rehabilitation of neck disorders. Professor Jull has published extensively in the field with over 250 journal publications and 38 book chapters. She is the editor of the Grief's Manual Modern Musculoskeletal Physiotherapy 4th edition, and has also published a textbook on the management of neck pain. In addition, she is also the co-editor of Manual Therapy, a leading international journal in musculoskeletal physiotherapy. Professor Jull also received an Australian Order Award in 2016 for her distinguished service to medical education in the field of physiotherapy as an academic, researcher, and administrator, and to professional associations. Professor Anne Moore qualified as a physiotherapist in 1973 and became a full member of the MACP by examination in 1979, and completed her PhD in the field of back pain in 1989. She also has postgraduate certificate in education and is a fellow of the Higher Education Academy in the UK. She is currently Professor of Physiotherapy and Director of the Clinical Research Centre for Health Professions at the University of Brighton, where she has worked as an academic researcher since 1980. She has presented over 170 keynote addresses at national and international conferences over the last 20 years, and she has published over 60 full-length research articles in peer-reviewed journals. Anne is the executive editor of Manual Therapy Journal and has been so since the journal was founded in 1995. She is also an editorial advisor to the International Journal of Osteopathic Medicine. Professor Anne Moore also received a CBE award for her service to physiotherapy in 2016. The topic of this plenary session today is state-of-the-art, expanding horizons in the future, and they're going to give us some insights about the way forward for manual therapy. Thank you.
Shows you how old we are when they talk that long on your CV, doesn't it? Actually, Anne and I are asked to just talk a little bit about future directions based on the experiences that we've had of the conference and the talks that we've listened to. And I'd like to also congratulate Joel. That was an extraordinarily interesting presentation. Okay, so I'll build on probably some of the things I said at the beginning of the conference. And one of the ones is that we've got to keep in mind the burden of musculoskeletal disorders. And we've talked during the conference about physiotherapists taking responsibility for the management of people with musculoskeletal disorders. And it's a huge responsibility. When you see that low back pain, neck pain, and other musculoskeletal disorders are in the top 10 of 301 conditions that are causing considerable burden to individuals and to society. Let's affirm that it's not a biological model, it's not a psychosocial model, that indeed it is a biopsychosocial model. The other thing that I'd like us to think about is that we often get the representation of the biopsychosocial model with these wonderful equal circles, but in fact that the model is very fluid, and it's very fluid between patients and even within patients, that many of them, some have a greater biological component, others will have a large social component with their working situations, others may have a larger psychological components to their problem. But again, as Joel has said, there is certainly no one-size-fits-all patient, and in the same perspective, there's no one-size-fits-all treatment. And the other thing I think we've got to be mindful of, and that we've learned in this week, is the clinicians and researchers must conduct their work within the context of the biopsychosocial model. And I'd say, remember Emma. Because again, she was in agonising pain, she was going on her hands and knees, she was calling ambulances, she was crying. Very easy to say, maladaptive pain behaviours, high anxiety levels, catastrophising, when in fact she had a very serious red flag biological condition. So I think it's one of the most important things is that we always think biopsychosocially and don't allow ourselves to be too biased one way or the other. So just a couple of thoughts following this week. One of the things I think we have got to do is we've got to define and contextualise the term chronic pain. Because what does it mean? And we've heard a lot of people talking about chronic pain this week, and I wasn't never 100% sure who they were talking about. So is it just defined chronologically, as has been, pain for 3 months or longer? Or is it people who have had more than 3 months of pain but have got involvement of their central nervous system? Or is it patients who have got 3 months of pain who have got a whole lot of psychological maladaptive features? Or is it patients, chronic pain patients, the ones who have got all of those other things? And I think it is very, very important as researchers and clinicians that when we start getting up here and talking about people with chronic pain, we make it very, very clear what group we're talking about. Because we've got Lorimer, for example, talking about regional pain syndrome, which is a horrendous chronic pain condition. But when he's talking about that, can I conceptualise this with somebody with a little bit of C2 zygapophyseal joint pain that they've had for 3 years? We've got to define what it is we're actually talking about. Also, this is a very common picture of neck pain, and this talk will be a little bit biased towards neck pain because that's what I know a little bit about. But when you see that, what is this? And what's happening at the moment is we're so often treating episodes of acute pain. But when you look at this, this is what the burden is. It's not so much that the person's got chronic, unrelenting pain, but they've got this recurrent episodic pain, which again is the huge burden that's being placed on them and society. And the other thing to keep in mind that regardless of what the time scale of the pain can be, people can sit in any one of these various, and I've given 3 configurations, but there'll be 100 or 200 configurations. But regardless of the time span of their pain, they can be in any one of those types of configurations. It doesn't condemn them to being a certain sort of patient. The other thing, and Joel, wherever you're sitting, you have no idea how much I enjoyed your lecture because he's spot on. And what he was talking about is absolutely spot on in that we've got to very, very carefully look at what we're doing, look at the mechanisms, etc. And until we start to identify patients, I think our outcomes in the RCTs, like he said, is not going to change. But I think we've also got to review our primary outcome measures as well. Because at the moment, most of our success of treatment is primarily based on researcher-imposed measures, whether it be a VAS or, for example, the Neck Disability Index. And there's increasing recognition of the discord and potential discord between these researcher-imposed measures and the patient's personal evaluation of the effects of treatment. And we had a lovely paper yesterday by Dave Walton, who's starting to try and recognising this fact and trying to actually establish what may be truer reflections of what the patient's experience is and what the change in their condition is. And so he talked about developing the Satisfaction and Recovery Index. And in that vein, I think there's got to be going forward much more qualitative and mixed methods research to inform outcome measures of treatment effects, because in a lot of the time, I don't think we're capturing them accurately. Now, pain may be suitable for evaluating the effectiveness of manipulative therapy, and certainly when we look at the trials, the primary outcomes usually is what is the effect of this treatment on pain, measured on a VAS scale, occasionally on an NDI, etc. But The other question I think we've got to ask is rehabilitation only about alleviating pain? Is that the only thing that we're interested in? You know, what are we trying to achieve with therapeutic exercise? And what's being evaluated in clinical trials of therapeutic exercise? And if you look, and I've just got half a dozen trials from the last couple of years, and it all is the main primary outcome, again, is pain, 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 or NDI. Now, think about that. Because the next question is stimulating an endogenous analgesic effect the only outcome we wish to achieve with exercise? That's all we're evaluating in clinical trials, so is that all we want out of our exercise? And think very, very carefully about that question, because in reality, if we only want to achieve an analgesic effect of exercise, we can forget those nice programs and all that research that's been done in developing rehab programs for various areas. And if it's only an analgesic effect we want, we can tell the patient to get on their bike. That's all they need, a bit of exercise. If we're thinking about the potential analgesic effect, it is a very unidimensional way of actually regarding exercise. And then we get these extremely curious statements, which are rather disturbing. Getting back to this one, this is another thing that we've got to think about in the long term, because basically our treatment should be to try to reduce the burden of musculoskeletal pain. So, for example, we heard a very, very nice presentation of the trial on cognitive, cognitive physical, whatever it was, from Limerick. Cognitive functional therapy from Limerick. And there were very nice results, preliminary results coming out of that trial. And immediately post-treatment with these people with their back pain, they've achieved about a 50% decrease in pain, which is quite impressive. But then when you look at the preliminary results for the 6 and 12-month follow-up, they're already starting to regress because their improvement in pain had reduced from 50 up to 30%. And so you can see that this person, if they got a good decrease in pain, they're virtually heading again for another episode of pain. And this is again where I think we've got to think more seriously about what we are trying to do with rehabilitation. And there's one thing about addressing the acute pain episode, but it's another thing to think about how are we going to stop these recurrent episodes of pain. And my suggestion would be, as part of core physiotherapy practice, is that we've got to be able to address the neuromuscular and sensory-motor control so that we can restore optimal support and function. We've got to address any work, personal or social drivers of the condition. And one of our big aims, I think, in physiotherapy or manual therapy is to reduce the recurrence and chronicity of pain. Because remember, the evidence is indicating that neuromuscular impairments do not magically disappear once the pain. They need specific attention. So as we've heard from Joel and from several other people during the conference, there's no one-size-fits-all treatment. We must be considering the biopsychosocial model. And I'd like to also give another example of that from an RCT that's just been completed by Kim Bonnell from the University of Melbourne, where we looked at a physical therapist delivered pain coping skills training program for knee arthritis. And just to give you a little bit of background, we looked at 3 interventions. One was an exercise intervention, another one was a behavioural intervention, and it was the pain coping skills program, and the other was the combined pain coping skills program plus exercise. So the combined program certainly was in accord with the Biopsychosocial Framework in which NEOA is placed, and so our hypothesis was that the combined program would be more effective than either intervention alone. So if we quickly look at the results, this ended up not being significant, but the green is the pain coping skills plus exercise, the brown dotted line there is the exercise only, the blue is the pain coping skills program only. So you can see a strong trend, even though we didn't get significance at every time point, that the combined program, if we're assessing pain, the combined program was superior to either program alone. And even in the WOMAC physical function, again, we got significant changes that the combined program was superior to the other programs alone. But it's getting down into looking into the secondary outcomes that I think are of interest and really are common sense. If we looked at the outcome from the DAS 21 on stress, not surprisingly, during the intervention period, the stress decreased in the exercise group, but really, overall, unless you'd received the pain coping skills training program, you didn't get significant reduction in your stress levels. Conversely, when we looked at the physical measure of sit to stand, the pain coping skills training program virtually did nothing to improve functional performance. You needed the exercise program, either exercise alone or exercise with the pain coping skills program to do that. So it's the old adage about horses for courses. We can't expect one treatment to miraculously fix every sort of component, and it shows the strength of working within the biopsychosocial context. Okay, I gave this list, and this is where it, I gave you this list at the beginning, where within that biopsychosocial context, we've got a lot of different things that we're going to consider, as well as the interaction between all of these factors when we're thinking about the patient's pain, functional limitations, and the withdrawal from participation. We've also heard about heaps and heaps and heaps of management methods over the week. But where to from here, if we're starting to think about the future? Again, Joel, wherever you are, I really did enjoy that presentation because he's 100% correct. What we've got to do, I think, is we've got to develop a realm of measures representing all facets of the musculoskeletal condition within the biopsychosocial framework. So we've got all of those sorts of things as examples of what might be going on. Now we have got some of the most incredible measures that we can measure things at a local level, right down to our physiological levels, our biochemical levels, going all the way through and looking at everything in the central and peripheral nervous system. So in other words, what I think's really got to happen to move us on is that if I want to give manipulative therapy, I want to know what it is doing at this physiological level. We're talking about Nina's, those T2, was it T2s or whatever? Yeah, am I changing them? What am I doing to psychological factors? What am I doing in the central nervous system? We know about all the cortical neuroplasticity. What am I doing with that with manipulative therapy? So in other words, what are the limits of manipulative therapy, good and bad? If I want to give a psychological intervention, again, I want to know, can it change things at this basic level? What is it doing in the central nervous system? What is it doing to neuromuscular function? What's it doing to sensory motor control? And in the same way, if I want to give a neuromuscular thing, again, I want to know what's happening, and I need to know what's happening at every level. And I think if we can set up some sort of model to investigate, it'll be a laboratory model to start with, that we'll then start developing quite true research-informed multimodal strategies. Okay, but we need to know what our treatments do, what they don't do at several levels, not just looking at a VAS. Okay, let me finish on this whole debate that we've had of hands-on, hands-off. We heard the impassioned plea by Brian Mulligan yesterday about manipulative therapy, and he's quite right. And all of us in this room have got the capability to give pain relief to patients as simply and as effectively as he showed us yesterday. We've got to have the skills to do it. And so I share with him his concern when schools are starting to withdraw manual therapy curriculum. It is a tragic event, and I think what people have got to do, and the clinicians can be very, very strong advocates to the school to say that they need this stuff in the curriculum, they need it in the curriculum. The other thing too is that You know, a while ago it was said, well, physical examination is no good diagnostically. You've got to remember that's old news. It's old news. You know, throw it away. The new news is that physical examination and the combination of movement and manual examination is highly sensitive and specific to diagnose a cervical zygapophyseal joint problem. We've got evidence of it. All the work with Toby Hall. The C12, the flexion rotation test, is highly sensitive and specific to locate C12 dysfunction. It is highly sensitive and specific to diagnose a C12 cervicogenic headache and differentiate it from migraine. We've got our bundle of physical tests that is highly sensitive and specific to identify cervicogenic headache from migraine and tension type headache. So make sure that you are preaching and making people preach contemporary news, not news of a decade, 2 or 3 ago, or last century's news. The other thing to keep in mind is that here we've got patients with chronic cervicogenic dizziness, 3 to 5 years, and this is a disabling condition. There will be high anxiety levels, there'll be great disability, yet 4 to 6 treatments you can see can very successfully make a significant impact on their dizziness. We can't give this sort of technique away. And I'll push again, if it's not taught in undergraduate curriculum, it will go, okay? It will go. It is so important. All right, I'll finish off. It is a biopsychosocial framework. We do, I think, need to know in a disciplined way, what our treatments are doing at every level of the system. The treatments in the future have got to be multimodal. And I hope to see you in Melbourne.
Well, thanks to Gwen, and we're getting close to coffee, so I'm going to be as quick as possible. I'd just like to move on. I'd just like to say I hope you're enjoying Scotland, and I really hope you enjoyed the dinner last night and the dancing, and I apologise to anybody who didn't really like me ferreting them onto the dance floor, but I'm trying to get a new professorship in dancing recruitment. Oh, thank you, thank you. So, some conference highlights for you that add to what I said at the beginning of the week. We had 1,321 registrations. 59 countries were represented here, which is brilliant. So in the future, we're expecting in Melbourne, maybe a few more countries, I don't know how more countries there are, but also a few more registrations. So that's the target. Speaker countries, 2016, we had 21 speakers 21 countries represented by our speakers. But in addition, we had 190 posters, which is the largest number of posters I think there's ever been at an IFOMPT conference. So we expect Melbourne to exceed those numbers as well. I'm just going to do some future directions for you, and I'm going to sort of focus on clinical practice a little bit. I'll talk a little bit about research, but these are based on what I've picked up this week, and also some discussion as I've had with various people outside of the actual presentations. What I'd like to do, first of all, is to say the buzz was enormous at this conference. I don't think I've ever been to a conference with so much buzz, enthusiasm and commitment shown from the audience. So I'd like to thank you all for that, because I think it's absolutely brilliant. And let's hope Melbourne can do the same or even better. So thank you. I'm going to clap you. I think also we need to think about, across all the countries, we need to increase the autonomy that musculoskeletal physiotherapists have within their clinical settings. So I think go back to your countries and actually think about that if you don't have some autonomous practice already in place. I think we all need to think about some routine, baseline, standardized data collection. And if we did this worldwide, it would be very, very powerful for us. This is from basic clinical practice. I think we also need, as practitioners, to ensure that we utilise patient-recorded outcome measures on a regular basis, not necessarily just for research activities, but on normal, everyday practice, so that you can actually utilise this in various ways. But one of the good ways that I've found that you can use it is actually to increase the discussion with your patients. So you look at the prompt that they fill in at the beginning, and you say, well, okay, but why is this happening, and what do you think this is doing for you, and what are you expecting? So get that conversation in fast. Tailored treatments, we've talked about this a lot, but we need to strengthen our tailored treatments, and as Nadine Foster nicely said during the week, matching patients to the right treatment. We also need to think about our communication skills. We need to enable and facilitate good communication with our patients, and this is vital, especially in tailoring treatments to their particular expectations and needs. And as Lisa Roberts nicely said, shut up, listen, and smile at your patient. Okay? I love that saying. I think we need to bring patient-centeredness to the fore, and hopefully that will gather momentum as we move towards Melbourne and beyond. I think we all need to think about educational theory and how much we know about educational theory. And I'm talking about learning needs and learning styles. And we need to ensure that educational skills and musculoskeletal skills are entrenched in our pre-registration programs. Very important, because we're seeing a little bit of a loss of some areas of musculoskeletal therapy in some pre-registration programs, which I think is worrying. And some programs don't actually talk about educational theory at all. Simple, and you can read about it, but it needs to be done in order for you to actually facilitate educational practice with your patients. I think also, we don't sell ourselves enough. You know, I think there's a good way of us collecting simple data about what we've achieved in practice, what influence that has had on our patients, but also on our colleagues, on our service delivery, on our managers. Why don't you all try and collect a simple case study and then publish it in your institution or your organisation, or maybe in your professional newsletter? It can really stimulate the value of our profession and our speciality, and that's what we need when we're trying to argue for autonomous practice, prescribing rights, etc. So, we need to stop the manual therapy decline. I think that's very important. And thank you. And Brian Mulligan made a wonderful speech the other day. I mean, I've never seen anybody get a full house standing ovation. So congratulations to Brian on that. And I think his passionate speech made everybody in the audience very passionate too. We've actually seen some strong neurophysiological research presented this week, and I'm sure that will go on, getting bigger. Independent prescribing was talked about quite a lot yesterday. I think that's on the cards for a number of different countries. So keep your eyes open on that and do what you can to have it in place in your own settings. Public health is important. We all make a very strong contribution to public health, or we can do, by making every consultation count. So not only dealing with tailored approaches to the patient's problem, but also thinking about the things that might actually enhance the problem for them, like smoking.